Hi, greetings everyone, and welcome. I think a little bit out of focus. I'm not sure why. Okay, focus. With me tonight and are two of my colleagues. I'll bring them on screen now. Betty Tay, Dr. Betty Tay, and Dr. Ahmad Nizar. Okay, so we are going to have a different format for CPD tonight, and instead of the usual lecture, we are going to have a debate between these two eminent cardiologists. It will be for medical therapy or for early intervention. And at the end of the debate, I think we'll let one present their points first, and then at the end of the debate, we can have some Q&A using Slido. So you might want to get ready to get on Slido. So go to slido.com and enter 38160 for the code, or you can scan that to visit slido.com at 38160 Slido room for this particular event directly. Okay, this is not the QR code for points. The points will show at the end of it, as usual, in the for you can scan with your MMA app and will display in this blank space. Okay, so what we'll do is go through the debate, both presenters, some Q&A. Then we'll end up with a poll because I want you guys who are listening to be the judges to see who won the debate, either Betty or Nizar. We think best well-dressed goes to Nizar. Sorry, Betty, got a tie.
Never mind, as long as I do win the debate. As long as I win the debate.
Okay. In the time tradition, we will start off with gentlemen first and then ladies second. So I'm going to share Nizar's slide. Yeah. So without further ado, Nizar will share his presentation, so you can switch to your keynote. Yeah.
Right.
All right. Take it away, Nizar.
Okay. You see my slides, right? Okay. Firstly, let me thank Alan for hosting this debate, and we would like to thank our sponsor as well. The current situation is whether coronary artery disease in stable angina is early intervention better than optimal medical therapy. So let me first define what stable angina is. Stable angina is typically in a person who has very stable symptoms that is induced by exercise and not at rest. And this angina is usually not of a crescendo type. It's not occurring at rest. Right? Now, what do I mean by early intervention? Early intervention would include cardiac catheterization and also percutaneous coronary interventions. And while with regards to optimal medical therapy, they should include at least 2 maximal anti-anginal therapy, a statin, an antiplatelet agent, and an ACE inhibitor. So that it's what optimal medical therapy is. Now, what I will be talking on would be coronary artery disease in stable angina. Early intervention is not better than optimal medical therapy. Firstly, let's look at what outcomes do we aim to improve in stable coronary artery disease. The first would be cardiovascular death and myocardial infarction. And then there would be symptoms. We want to try and improve patient symptoms. And finally, we should also target myocardial ischemia. Now, in most situations, myocardial ischemia is probably used as a surrogate for cardiovascular death and myocardial infarction. So let's start with what medical therapy has to offer. I think we are all aware that the benefits of aspirin or antiplatelet therapy, and the benefit is definitely outweighs the risk of bleeding in high-risk patients. In this meta-analysis, you find that in people with previous myocardial infarction, as well as a previous stroke, they generally benefit from the use of aspirin. The statins are also important in people with stable coronary artery disease to reduce their risk for cardiovascular events, particularly coronary and major vascular events. Now, this came from the meta-analysis from the cholesterol treatment trialist collaborators. And what it shows is the 14 different randomized trials that has been included in the meta-analysis. And when you looked at the proportional reduction in event rate by every millimole of LDL cholesterol, you find that there is a major reduction in major coronary events as well as major vascular events. We looked at ACE inhibitor as well. If you looked at the two trials that are well known to show that it can reduce the risk for myocardial infarction and death are the HOPE trial and the EUROPA trial. In the HOPE trial, they included patients with high risk, and it showed that it can, if you looked at ramipril at 10 milligrams daily for 5 years, reduce the primary endpoint of composite of MI, stroke, and cardiovascular death. In the Europa trial, perindopril 8 milligrams daily was used, and it too showed that it can reduce the composite outcome of cardiovascular death, MI, cardiac arrest versus placebo. So with symptoms, we know anti-anginals are effective, and almost all anti-anginal therapies are equal. I've picked trimetazidine as an example here. In your right-hand panel, you see a meta-analysis of a systemic review in people given trimetazidine and the outcome of anginas per week. If you looked at monotherapy as well as combined therapy, trimetazidine is better, or it improves symptoms. In the left panel, you see the use of trimetazidine in a new formulation, in an 80 milligrams daily formulation, in naive patients and in patients who were switched from the old formulation. And you see that at baseline, at 1 month, and at the third month, you see a reduction in their symptoms. If you looked at the effect of ST depression during exercise, that is the time to 1 mm ST depression, the combination of trimetazidine and metoprolol is effective in actually increasing the time for 1 millimeter ST segment depression. And in the same meta-analysis I showed you earlier, in the right-hand panel, you see that as a monotherapy as well as combined therapy, the time to 1 minute ST segment depression is increased with anti-anginal therapy. Now, you'd be surprised that myocardial ischemia can also be improved with medical therapy, despite the fact that we don't do anything to the fixed obstruction. And here is an example of the effects of ranolazine on the stress myocardial perfusion imaging. In the upper panel, you see at baseline, when the peak heart rate achieved was 142 beats per minute, you compare the polar plots at rest and exercise, and you notice that there is that dark space in the left circumflex territory that suggests that there is reversible perfusion defect. Now, after the patients were given ranolazine for 4 weeks, and the exercise test is repeated with equal heart rate achieved, you see that the reduction in the myocardial perfusion defect is apparent. And this is not for a single patient. They did not choose the best results. But if you look at the 21 patients, the improvement in ischemia in the polar map is actually significant. So let's look at what coronary intervention has to offer for the similar targeted outcomes. In the first trial, this was the optimal medical therapy with or without PCI for stable coronary artery disease, or COURAGE. This was actually a trial that was ran from 1999 to 2004, and it was published in a New England Journal in 2007. It was designed to determine whether PCI with optimal medical therapy reduces the risk of death and non-fatal myocardial infarction in stable coronary artery disease as compared to optimal medical therapy alone. In this trial, the drug-eluting stent was not approved for use until the final 6 months of the study. In the exclusion criteria of the trial, people with persistent severe angina was excluded. In patients with markedly positive exercise stress test was also excluded. Refractory heart failure or cardiogenic shock and EF less than 30% were not included in the trial. And patients who had revascularization, either PCI or bypass surgery, within the 6 months, and obviously anatomy not suitable for PCI was not included. Now, they actually randomized about almost 2,300 patients into the two arms. And the primary endpoint was actually was death from any cause or non-fatal myocardial infarction. When at the end of the trial, we looked at survival free of death from any cause and myocardial infarction, there was no difference in the Kaplan-Meier curves of both medical therapy and PCI. And obviously, the hazard ratio was not significant. Now, what they concluded was, as an initial management strategy in patients with stable coronary artery disease, PCI did not reduce the risk of death, myocardial infarction, or other major cardiovascular event compared to optimal medical therapy. The second trial I'd like to show you is the ORBITA trial, or the percutaneous coronary intervention in stable coronary artery disease. This is a double-blind randomized control trial designed to investigate the efficacy of PCI versus placebo to improve exercise capacity in patients with coronary artery disease. Now, symptoms and exercise capacity is one of the targets that we target to improve in patients with stable coronary artery disease. And in this trial, for the first time, they had a placebo arm in the PCI group as well as the placebo group. So patients were enrolled, and they were given a questionnaire with regards to the severity of angina, and they were put into a 6-week medical optimization phase where the anti-anginal therapy were maximized. And then at pre-randomization, they were again given a questionnaire and see how their symptoms have improved. And they did a dobutamine stress echo on the patients. And once they were randomized either to the PCI group, and angioplasty were actually guided by physiology for ischemia. In the blinding phase during the angioplasty, patients were put on headphones, they were sedated, and a 15-minute wait was actually applied to all patients. The clinical team, in both arms, patients were in placebo as well as the PCI arm, were given double antiplatelet therapy, and same procedure instructions was given at discharge. The clinical team was also blinded from the randomization groups, and in both arms they were treated as if they had undergone PCI. So in this trial, the exclusion criteria was stenosis of more than 50% in non-target vessel, acute coronary syndrome, previous bypass surgery, left main stem disease, severe left LV impairment, moderate severe pulmonary hypertension, and life expectancy of less than 2 years. The primary endpoint was the difference in exercise time increment between the two groups. Now, what they found was the primary endpoint results was that between PCI and placebo, there was no difference with regards to the exercise time in total. So they concluded that in patients with medical therapy treated, PCI did not increase the exercise time by more than the effect of placebo procedure. And so up to this point, what was missing? The previous trials were suggested that they were underpowered for death and AMI. And there were potential inclusion bias in the COURAGE trial in that the angiogram was not blinded at enrollment. And there were already advances in medical therapy by then, like stents and in bypass surgery. And a randomized controlled trial testing is required to suggest if revascularization is more effective in more ischemic patients. So just this year, a trial was published, and that was the ischemia trial on stable coronary artery disease. And this was actually a trial on moderate severe ischemia in the mildly symptomatic and moderately symptomatic patients. And the idea is to suggest or to show whether early invasive strategy actually improves prognosis. So the around about more than 5,000 patients were actually randomized to two arms, one invasive and the other conservative strategy. And the primary endpoint was a composite of death from cardiovascular causes, myocardial infarction, hospitalization for unstable angina, heart failure, and resuscitated cardiac arrest. The major exclusion criteria was that of left main stem disease. The others were severe angina despite maximum medical therapy, acute coronary syndrome within the last 2 months, PCI cabbage within the last 1 year, New York Heart Association between 3 and 4, a left ventricular ejection fraction of less than 35, and an eGFR of less than 30 or near end-stage renal failure. Now, these patients were stable. They had moderate to severe ischemia. What was unique to ischemia was the patients were actually asked to do a coronary CT angiogram, and the results of which were sent to a core lab and screened before they were randomized into two groups, one for invasive strategy and the other conservative strategy. And the result shows that between the invasive strategy and the conservative strategy, the Kaplan-Meier curve did not show any difference. And obviously, the Cox regression analysis too was not significant. With that, I end my first part of the talk, and I will come back to do a rebuttal after Dr. Betty has given her presentation.
Thanks, Nizar, for keeping to time. I forgot to mention it will be 20 to 25 minutes per speaker. So I think we'll move on to Betty now. So over to you, Betty.
Good evening, everyone. Thank you, Nizar. I hope my slides won't be as busy as this. It looks like patients with polypharmacy when they are not treated with intervention. So I will start my slide by saying coronary artery disease is the leading cause of death worldwide. And as doctors, our aim is always to reduce the mortality. It contributes to 7.2 million deaths annually. And the majority of death is attributed, of course, sudden death and also unstable angina. Early revascularization for acute coronary syndrome is well established. For example, if you have an ST elevation MI or a non-ST elevation MI, we would like to revascularize you. All the data shows that it is beneficial for patients. But optimal management of stable coronary artery disease is still controversial, or is it? Now, stable angina is of course related to coronary arteriosclerosis. Symptomatic condition causes poor quality of life and frequent use of healthcare services. It affects about 5% of the adult population years old. Highly variable long-term prognosis. I think Dr. Ahmad Nizar never said that. And have a poorer CV prognosis compared to a general population. Okay. The optimal management for stable coronary artery disease is controversial. Yes, antiplatelet has been established. Yes, statin must be started, and of course, there is your ACE inhibitor. But all the anti-anginal actually does not confer any reduction in mortality by itself. It just reduces the risk of having chest pain. In 2012, in a meta-analysis of 7,000 individuals, PCI was compared to medical therapy. Again, PCI did not reduce the risk of mortality, CV death, and non-fatal revascularization. And at this point of time, are you saying, are you for intervention, Betty, or are you for medical therapy? But it was associated with greater angina. But this meta-analysis was way before the contemporary era of third generation. Yes. And then we had REACH, which was a 4-year follow-up study. They studied patients with angina, and they had higher risk of future CV death, MI, and stroke. So patients with angina, the angina in itself was a predictor of higher rates of future CV death, myocardial infarction, and stroke. More patients with angina were more susceptible to heart failure, CV hospitalization, and coronary revascularization. Interestingly, in this study, lower risk patients with angina had more recurrent CV death. Means patients whom we thought were of low risk, but with angina had more recurrent CV events. Myocardial ischemia, which is rather than angina itself, means that we can quantitate the ischemia either by a stress test or myocardial perfusion scan, was a stronger predictor of future CV events. So with this trial, we know that angina and ischemia increases your risk of a future CV event. Courage, which I think Dr. Nizar touched on, was published in 2007. It was designed to assess the impact of adding PCI therapy. It did not demonstrate superiority of PCI added treatment, but again, the PCI arm proved to decrease angina. And again, we know that angina is eventually ventral severity and events. Okay? But many doctors, as we already know truth, many doctors dismiss this study because of the lack of objective evidence of ischemia. So the unsolved issues are 10 to 30% of optimally treated patients with stable angina pectoris tend to experience symptoms. So the symptoms do not go away with treatment or medical therapy. This results in low quality of life and increased CV death, and then imposes a great economic healthcare burden. So symptoms then become an important consideration treating these patients. Angina, again, is a predictor of outcome. Several studies in the last 3 decades shown that angina to have a impact on the outcome of CV death, mortality, and morbidity. The HOPE study in itself that Dr. Ahmad Nizar presented, it did not say that persistent angina was an independent predictor of long-term major cardiac event and rehospitalization. In the heart failure action trial, angina was associated with health of life and had a 20% adjustment. In the Clarify trial, patients with angina had increased CV death and non-fatal MI compared to patients with symptoms. So angina is a very important criteria to look at. And yes, when we look at PTCA versus optimal medical care, Circulation published in 2012 a meta-analysis of 12 randomized with a total number of 7,000 participants. This included the REACH and COURAGE study. Revascularization with PCI was again associated with greater angina risk. So there is no doubt no longer that PCI relieves angina. And then angina is predictor of further outcome. PCI did not reduce risk of mortality, CV death, or non-fatal MI. Okay? But these studies was follow-up was between 1 year and less than 5 years. It's a trend of benefit. 5 years, patients with more than 5 years follow-up in both mortality and CV death. And if you see the diagram that the chart that Dr. Ahmad Nizar showed you earlier, the ischemia trial, there was a diversion at about maybe a year or 2 years. Okay. Now there was no standard, but this circulation meta-analysis, there was a study bias. Of course. There was no standard definition of stable coronary artery, stable angina. They looked at varying angiographic definition, and only a minority of them had symptoms of. And older trials, they used balloon angioplasty, which was proven to be inferior to the angioplasty 90% patients. Intervention now is a different ballgame to what you see 5, 10, 15 years ago. Okay? Now we have DES, which is drug-eluting stent, which is the mainstay of treatment. Great advances has been made in the field of putting and polymer in the stents. Okay? Procedure is of low risk with minimal risk of acute or subacute. Thinner struts in the stents reduces in-stent restenosis even without the aid of drug. Okay? And now DES, a lot of the stents have shorter duration of anti-therapy. With combo stents is only about 3 months. And restenosis rate is less than 5%. Okay? Now, procedure is of course the same, but the equipment stents that we use when angioplasty is done, we can actually do it either through a radial or femoral. We actually guide the wire into the intraluminal space of the artery, okay, to make sure that we are not out of the. Once we are sure that it's in the artery, we balloon it and then we stent it. Okay? It is as simple as ABC. Okay? And it is naive, even dangerous maybe, to blanket all patients with stable angina. In 2016, Beto Barbero performed a meta-analysis of 4 studies among patients with stable angina. The most predictor of MACE was male, reduced ejection fraction, diabetic, prior acute myocardial infarction, ICR. A lot of them were excluded from trials that randomized patients to prevention or therapy, which I will demonstrate later. Now, Dr. Nizar's top points for optimal medical therapy is based on this trial, ischemia trial, where it randomized 5,000 patients with stable angina to initial invasive therapy or conservative therapy. All patients received guideline-directed optimal medical. They excluded patients with cabbage. Okay, they followed up patients for 3 years. I'm doubtful this is enough. And worse, they excluded patients of high risk. They excluded patients that had unprotected left mains. They excluded patients with class 3 and 4 heart failure. They excluded patients with intolerable angina, a recent MI, and ejection fraction of 5%. They had, what they found was, yes, there was no benefit in certain primary endpoint, but in the ischemia trial, there were lower spontaneous MI in the invasive arm. There was a lower rate of hospitalization for unstable angina, the invasive arm. The burden of angina related to conservative treatment is not without its consequences. OMT arm patients had more visits to the outpatient and the emergency room. Economic burden was not factored into this equation. An invasive arm means patients had PCI done had greater improvement in disease-related health status. They could exercise more, they had a livelier lifestyle. Okay? But what was most important is this FAME trial. FAME2 trial, okay, studied patients with stable angina. And this FFR is actually a wire. If I were to explain to you, so it is actually a wire that is placed into the artery to assess whether the stenosis is significant or not. This fractional flow reserve wire is a measurement, helps us measure the functional significance stenosis intra-procedure. All stenosis were assessed in the FAME2 trial, and an FFR of 0.8 were randomized to PCI plus medical therapy or just primary endpoint was death, MI, and urgent revascularization. The trial was terminated prematurely. And this was because there was a highly significant difference in the incident rates of primary endpoint favoring PCI. So they stopped randomization. The significance in the primary endpoint of urgent revascularization was beneficial within 8 days of randomization. Means when you have done the PCI, you actually see benefit within 8 days. Benefit of PCI in respects to death and MI become more pronounced with increasing duration of follow-up. FFR guided approach is associated with better clinical, but we may not do FFR guided approach if we really objectively quantify the ischemia in patients when we randomize them. Only DES was used and there was a low number of repeat revascularization. In conclusion, this FAME trial can show you that patients with significant stenosis do worse with optimal medical. Now you must remember, okay, 95% stenosis doesn't mean you're 95% dead or have a 95% chance of dying. Significant part is may unlikely to cause infection. Infarction is due to plaque rupture and more likely to happen in minor unstable plaques. So patients with coronary artery disease probably have generalized and multiple plaques, some more significant than others. And coronary artery disease is not about one single lesion. So I want to pose to you or explain to you this open artery hypothesis. It was first proposed by Eugene Braunwald. Patients were recanalized of infarcted related arteries. And they did angioplasty for these patients. Okay, initially we thought that the survival was due to myocardial salvage, means that we were able to save myocardium. But we realized that opening up an occluded infarcted related artery, whether early or late, reduces survival rates. There is disproportionate amount of myocardium salvage. So let me explain further. Now, if you have three major blood vessels, as you can see here, okay, this is the left coronary artery, which is actually occluded. And this is actually the right coronary artery, okay? And then there is actually collaterals going up, supplying left side. Collaterals are actually anastomotic connection between the same or different coronary artery. They occur naturally, means you don't have to do anything. They can grow few days. Okay? It provides an alternative source of blood supply to myocardium. It may be sufficient in some patients to meet myocardial needs rest, but it's never sufficient to meet myocardial demand size. Now, what is the clinical significance of in the setting of myocardial infarction? Collaterals have been shown to preserve myocardial function, limiting infarct size, and positively influence post-infarct. It reduced mortality. It reduced frequency of cardiogenic shock. And over an average of 12 studies, mortality was reduced about 5%. So an open artery is very important to ensure adequate collateral formation. Another artery is open. That is my point. Yes, maybe the open artery hypothesis was based on an ST elevation myocardial. But if you were to extrapolate this hypothesis, any open artery, it is very important, okay, to have an open artery all the time. Ensure that when another artery is closed, okay, other arteries will provide collaterals to it. So in conclusion, yes, optimal medical therapy is not bad, but treatment should be individualized. Analysis of plaque is important. Symptoms and objective assessment at ischemia is paramount. The benefit of FFR decision making is crucial. Patients with high risk, stable plaque should be revasculated, and is better early than late, as the progression of plaques can make the procedure from simple to complicated. It is, I win.
Well, not decided yet. So rebuttal time. So we'll maybe 5 minutes each because time is running out. Roughly 5 minutes is okay. So
Just 5 minutes.
Nizar, I will add your slides back in, then you can rebut Betty's points.
Right.
So for those who come in late, Dr. Ahmad, Nizar is for conservative management and Betty is for intervention. Okay, in stable angina. Yeah.
Okay. I think the question here is not that whether PCI is effective. It is effective for acute coronary syndrome. But in coronary artery disease, what we've always been using is that ischemia predicts cardiovascular events. And what I would like to put forward is that the causal pathway of acute myocardial infarction and coronary death is different from that of angina. If you look at coronary artery disease, and the red line is actually the pathway for AMI and coronary death. What occurs usually is plaque rupture, and following plaque rupture, you get acute myocardial infarction. So intervention like stabilizing this plaque, like statin, protects against acute myocardial infarction. While if you looked at ischemia that causes angina, it is on a different pathway. Angina does not cause acute myocardial infarction, and therefore intervention in reduce ischemia, to reduce ischemia, for example, PCI, has always failed to protect against acute myocardial infarction, right? So we talked about FAME2 earlier. This is the findings of a meta-analysis that looked at all the effects of PCI on stable coronary artery disease. And in panel A, you see the effects of all the trials on death. And it doesn't actually improve prognosis, PCI, in people with stable coronary disease. Despite that, you can improve ischemia, but it does not improve the incidence of myocardial infarction or death. If you look at the frame B, that is for non-fatal myocardial infarction, that too did not show any difference that favors PCI. While if you look at frame C, that is unplanned revascularization, here frame 2 appears to be unusual in that it is very significant. That was the results of frame 2. And in the final frame D, if you look at angina, again, frame 2 was the one that made the PCI favorable. And let me explain why that is so. If you look at frame 2, and in this, in the patients with PCI as well as those that were randomized to the optimal medical therapy, what each of these colors represent is actually the patients in the Canadian class 4 of angina, and in orange it is myocardial infarction. In green, it is the presence of ECG changes, and in green you see in for clinical features only. So you will see that in people with in the group with optimal medical therapy, what drove the revascularization rate was mainly symptoms rather than myocardial infarction or ECG. And the reason for that is the patient as well as the operators were unblinded, and immediately after they had the procedure done, they were told that they did not have a stent. And it appears that when you tell a patient that they did not have a stent and no procedure was done, when they have a significant narrowing, their symptoms became worse, and as a result they get revascularized earlier. And if you looked at what drove the primary endpoint, it was urgent revascularization, not death or myocardial infarction. Now, truth passes through 3 stages. First, it is ridiculed. Secondly, it is violently opposed. But finally, it's usually accepted as being self-evident. So I'll pass it back to Betty for her rebuttal.
So wise, but yet so silly to believe that optimal medical therapy is better than. Like, how come I'm back here? Sorry, sorry. This is not a sign of me jittery. It's just being clumsy.
You're conceding, is it?
Okay. Now, I think Ahmad Nizar earlier in the slide, he actually presented the orbital trial. But because his slides were so busy, we don't know what he was presenting. The orbital trial did not show an improvement of exercise tolerance. Okay? The patients had FFR and 200 patients were randomized. So basically, this trial is actually a very good trial. Patients were randomized properly. They all had FFR, okay? But the duration of follow-up was 6 weeks. Okay? How do you make any statement from a duration follow-up 6 weeks when you know that, okay, the natural progression becomes worse as the duration of disease increases? And these are not my words. These are the words of the people who studied the trial. They say that this is clearly a landmark trial, but several issues need to be considered. The trial was extremely well done, no doubt, with careful assessment of ischemia pre and post procedure, and the appropriate use of anti-angina medication. Although powered for exercise treadmill-based endpoint, the trial appears too small, 100 patients, to address a question of this magnitude. The Courage trial, for instance, enrolled 2,000 patients with stable angina. Moreover, the changes in the treadmill score and exercise time was both numerically higher in the PCI arm, and it is unknown if a larger sample size would have detected more modest improvement in exercise capacity. And then we have this ischemia trial, which again we say it's proper trial. It is recently published, but please remember that Dr. Ahmad Nizar failed to tell you that it took 10 years for the ischemia trial to reach patients. 28% of the patients in the conservative arm eventually underwent cardiac catheterization, either because of an acute event, failure of therapy, poor compliance of polypharmacy causing need for revascularization for 8%. Did he mention that? I don't think so. 5,000 patients, more than 400 in the invasive strategy group did not undergo revascularization, as 200 over of them had no obstructive disease to start off with. 11 had no revascularization despite having significant stenosis due to anatomic difficulty, and 28 patients refused PCI. So I think he didn't mention all this. And then he didn't mention that the patients in the ischemic trial was too heterogeneous. They included patients with and without angina. And we know that angina, the presence of angina and ischemia, objective ischemia, is a predictor, okay, of CV events. And worse, the trial excluded patients with intolerable angina. Patients were assessed with various modality of ischemia, okay, for ischemia, and yet many that were included had non-obstructive disease. 35% of patients in the ischemia trial did not have angina even at baseline. 44% of patients had angina less than 3 times a month. And due to the slow recruitment and low event rate, the primary endpoint was changed after the trial commenced, just before they unblind. Primary endpoint of cardiovascular death and non-fatal MI. Then they included admission for cardiac failure and resuscitated cardiac, all of which I'm sure. And 13%, as I mentioned, in the invasive arm had no obstructive coronary artery disease whatsoever. Now, this is my mom. She is a lady who opted for intervention. Okay? Early intervention, she's 82 now. Because she opted for early intervention, today she made her debut as a model. Ini adalah kisah benar. This I end my. And I'm sure I will win this.
Well, we'll let the audience decide. But first of all,
Please
let's
let me win, please.
wait. We'll come to the votes. Can we have any questions? So my esteemed colleagues have presented their points for and against PCI. That means whether you're more for conservative optimal medical therapy in stable angina, or do you think we should intervene with PCI? Anybody wants to make any comments? Facebook, YouTube,
You can't hear
Slido.
Yeah.
Your audio was a bit broken up, Betty, unfortunately. Yeah. Never mind. I think you had slides though, so we could make out what we were saying. Yeah. Still a bit broken up. Must be the state of broadband. Any questions? Anybody from Facebook or so? Nobody saying anything. So I think thank you all for I'd like to thank the debaters for keeping to decorum, unlike politics in America where people interrupt each other. It gets very emotional, heated up. You guys have nicely kept to your time and point. So what I'll do is share the voting panel. 1 second, yeah.
It's a drum
It
roll.
didn't drum roll. Okay, I will share the poll now. Who do you think won the debate? So can you guys please go to slido.com 38160 and cast your vote. It's anonymous. Betty, you voted for yourself. Wait, it's only one
No,
vote.
I didn't vote at all. I didn't vote at all.
Okay, all right.
Oh my God.
Neck to neck.
Hey,
Okay.
come on. Please. Oh my God. You should have stopped voting immediately. Okay, stop voting now. Stop the voting now.
You cannot be like the Republicans and say, stop the voting now when you're winning. Yeah.
Okay,
We're going to
stop the
let
voting
everybody
now.
cast the vote. Yeah. We will have, we'll give a minute.
Come on, Ahmad,
Everybody
Nizar.
please cast. Yeah.
If you win, we will not have a job. Okay. Oh, I think I won.
But the point about myocardial infarction is not so much the severity of the stenosis, but it's the stability of the plaque. Is that true?
Yeah.
Oh, yes.
That's what I was getting at.
Stability of the plaque is very important. But you see, what I'm trying to say about the open artery concept is, if you don't open up an artery when it's blocked, and I'm talking about significantly blocked. When another artery is blocked, then you have two arteries that are blocked. You want that, Alan?
Now, how can you tell? Okay, we can only tell the degree of the stenosis. Is there any test or objective way to say how stable the plaque is?
Oh, that is difficult.
You still need
Stability
to
of
do
the
an
plaque is
invasive
a very difficult concept. Very difficult to apply objectively. So that's why it is very important that you patient statin. Statin actually stabilizes.
Okay.
So
That's not
statin,
to say that
aspirin,
I'm for medical therapy
inhibitor.
alone.
Yes,
Yeah,
Nizar,
No, I
you will
think
take
I think it is not mutually exclusive actually. What we are getting at is actually you don't have to intervene early, but you have to be on your toes, because what improves prognosis is if you do PCI for unstable angina acute coronary syndrome. For stable patients, the medical therapy is the important part. That stabilizes the plaque and prevents events actually. Just like I say, if you looked at, Betty said that anti-anginals do not improve prognosis. That is true because for the same reason, angina is not actually a predictor of myocardial infarction. It's the stability
That's
of the
not
plaque.
true. That's
That's
not
why.
true. I have
So the
meta-analysis. I show
angina,
you.
you can't. You look at all the trials. The trial shows that if you were to treat ischemia, it doesn't improve outcome. That is the trial all about. Courage, Obita, and ischemia. It shows exactly that. If you treat ischemia, it doesn't improve outcome.
Ahmad, Nizar, you're winning. You don't have to talk anymore. You're winning, okay?
So can I say as non-cardiologist, we say if the outcome is cardiovascular mortality or myocardial infarction, there doesn't seem to be much difference between intervention and optimal medical therapy. But when it comes to control of angina, PCI seems to be
PCI,
better. Is that
correct?
That's the gist of it? So
The gist of
actually, to my mind, both of you win to some extent. I mean, optimal
No, it's
medical
actually
therapy
about
has
patient
been.
selection. Okay? In stable angina, okay, you can afford to select your patients better. So it is not a blanket rule. Not like when they come in with an ST elevation MI, you have to do something. you have to intervene. Or they come in with a non-ST elevation MI, when the plaque is not stable, you have to intervene, and the sooner the better. Whereas in a stable angina, you have um, can select patients, and you have to select patients. Those of high risk will definitely need early in. If you have a patient with blockages and with an LV function of, let's say, poor, that's 30%, okay, you would want to intervene as early as possible, because then allow in its LV systolic function. Okay, if he
So
has angina or no angina.
you need to intensify risk factor management. Actually, that helps in actually preventing MACE, and really strict risk factor control. I mean, strict diabetes, strict hypertension, strict cholesterol, that sort of thing that you need to implement. But a patient's choice is important. And I think at the moment, patients do believe that PCI actually prevents death and myocardial infarction. So you get a lot of patients demanding that you do PCI. But you need to try and convince them that they need to control their their risk factors. That's the big thing, actually.
Sorry, I will remove that. You're a bit covered by the comment by Harris now. In this time and age, intervention should be individualized. Physiological significant stenosis, revascularized significant medical therapy. The gray area should involve judgment and do the appropriate for the patient. The need for the cardiologist to make a decision so cardiologists will not be out of job, even though they opted for medical therapy.
There's actually not much of
Comments?
a gray area. But I want to comment something. I'm now looking not just at this stream yet, I'm looking at the live chat on my handphone. And I realized that there are more women tuning in. No wonder Ahmad Nizar is winning. There is
Must be my tie.
Uh,
my
maybe
local
I think
well,
both of you had good points, and I think they're very good take-home messages. And it doesn't mean we cease to notice straight away PCI either, isn't it? Would both of you agree?
no, of course not. Because actually you need to really see whether there's ischemia or whether it is significant or not, blockage. So
Yeah.
FFR is useful, okay, more
What is
useful than
FFR? Could
it's
you?
again a wire that can measure, okay, whether the stenosis is significant or not.
Okay.
Yeah.
I
So
All
the
think
right.
if you look
pressure,
at the exclusion criteria of all the trials, that's why I mentioned the exclusion criteria. And those patients, early intervention is important, right? But otherwise, they can actually be included as the group of patients that actually can go on medical therapy first before considering invasive
I'm so
therapy.
sad you.
Okay. So winner of the debate, Betty, I'm afraid, is Ahmad
Oh,
Nizar. So congratulations, Ahmad Nizar. So optimal
ayo,
medical therapy beat out
my ego
PCI
has
for
been
stable angina.
dented.
Yes, by 70 to 30%. So two-thirds of the votes went to Ahmad.
I feel like
Congratulations.
Joseph Biden.
I need a recount. I want a recount. I insist on a recount. Okay.
You're
Okay,
gonna take it
now
to
comes, yeah. All right, so thank you everyone for watching. So I won't forget to show what is important. So I think there were no other questions or comments. So we'll go on to the part for those of you who've been patiently waiting for.
Oh,
That's the claiming the CPD points. So, and here you are. Please scan. The speakers get 5 additional points, which will be manually uploaded. I hope the MMA app is not giving problems because the server
I
was
can't go in.
really
Oh,
overloaded in the last 1 or 2 weeks.
Oh,
If it's not loading, you just be patient. Wait a while, it will load.
oh my God.
Yeah,
Tomorrow my
that's
follow-up
what.
clinic has 20 patients, all waiting for me to do PCI, I hope.
But it won't load. The software won't
Yeah,
load.
the app is not loading again. Oh dear. Let me
Can you just
inform.
put in for me, please?
Yeah,
When
we'll
you put
put
in,
in.
thanks so much.
But how do the audience scan actually if they can't log in?
What they can do is message Couture Docs at WhatsApp or Telegram, and we'll manually add in your points, provided you're a registered Docs member, and preferably you registered for the event. Okay, but anyway, I will re-upload another code a bit later. But the MMA app is loading now. It's very slow. So I think the
Very slow.
issue MMA had is the server has been overloaded. Okay, I finally loaded
Okay.
it. So be patient. It may take 1 minute of you see a spinning wheel, then it should be able to scan after that. Okay. Yeah, I managed to load and got the point.
Yeah, so did I.
So yeah, yeah.
Okay, okay.
So just be patient. Yeah, the server can be a little bit heavy. Yeah.
Wonder Ahmad Nizar wear jacket, tie and everything. So sad.
Yeah. MMA app is laggy. Yeah. Okay. So yeah. So the comments are coming in. They've got it. Can load. All right. The code will be valid for 1 hour. Okay. So guys, it won't take too much of your time. It's just 9 o'clock now. 9:05. We've just exceeded the allocated time by 5 minutes. So I'd like to thank Betty Tay and Ahmad Nizar for entertaining debate between PCI and optimal medical therapy for stable angina. Our panel of judges who were watching voted for in favor of Ahmad Nizar, though we think the ties swayed the vote. So the looks count, Betty. The looks count.
Ah,
uh,
I need to get
oh,
my male
All the
fans
trick.
in. See you
yeah,
guys.
yeah. All right. So anyway,
All right.
thank you all for watching. So the code, it should work now. The MMA app is loading, so the code will be valid for probably at least another half an hour. But if
Okay.
you're catching this like this tomorrow or something, I'm afraid the code won't work anymore. But we may have a reboot event, and then we'll generate a fresh QR code in the future. Okay, so thank you. I'm going to end the broadcast now. So thank you everyone for watching and tuning in. Okay, see
Okay,
you
Merry
next
Christmas,
Wednesday.
Happy New Year.
Thanks,
Yeah,
Helen.
yeah. Thank you all,
Thanks,
and see
Helen.
you all next Wednesday. As usual, next Wednesday, 8 p.m. There'll be another event. We announce it in DOBBS Facebook and DOBBS Telegram. Okay. Good night.
Good
Okay.
night.
Night.